Welcome to UMDF's Ask the Mito Doc Monthly webcast. Tonight we will hear from Dr. Mark Tarnopolsky, Professor and Head of the Neurometabolic, Neuromuscular, and Neurogenetic Division in the Department of Pediatrics at McMaster Children's Hospital. He is widely recognized as a global leader, and tonight we are fortunate to have him share his insights and expertise with us regarding diet, nutrition, and nutraceuticals. Our moderator for the evening is our very own Margaret Moore, UMDF Associate Director of Support and Education. Let's get started, Margaret.
Hello, everyone, and welcome to Ask the Mito Doc. I want to get started by thanking our sponsors, Edith L. Trees Charitable Trust and UCB. Well, let's get started. I am excited to introduce Dr. Mark Tarnopolsky. Hi, Dr. Tarnopolsky, how are you?
Well, thanks. Thank you for allowing me to speak tonight, and I appreciate the invitation as always.
Well, we're very excited to have you. I'm going to get you to share your screen, and then I'm going to pop off camera, and we'll get this ball rolling.
Good. Is that working?
Perfectly. Thank you, Dr. Tarnopolsky.
Excellent. So as mentioned, I'm Mark Tarnopolsky. I'm a professor of pediatrics and medicine at McMaster University. I specialize in metabolic and genetic disorders that affect the neurological system. Mitochondrial disorders is probably the biggest group that we see in the clinic. So from a disclosure perspective, I have received several speaker honoraria and been involved in several clinical trials, none of which I'll talk about tonight because the main clinical trial I'll talk about I funded through my own personal income several years ago, since nobody would fund me at the time. I am the founder and CEO of Exerkine Corporation Stay Above Nutrition, and we are using essentially the core components of what I funded my self-funded clinical trial years ago and showed was helpful for mitochondrial patients to form the core of products for people with different secondary mitochondrial disorders, things like type 2 diabetes, obesity, fatty liver disease, and aging. Those products are commercially available in Canada and soon in the United States. Some may be of interest to patients with mitochondrial disease, but in full disclosure, I am involved in that company. However, to avoid conflict of interest for our patients and to support both muscular dystrophy and mitochondrial patients around the world, we have discount codes. And the discount codes for any of our products, I can give you right now if anyone's ever interested. It's NMC20. So that's capital N, capital N, capital N, capital M, capital C 20, because that gives a 20% discount, which eliminates the margins on many. And we lose money on some products like creatine because we're trying to give back to the community. So just in full disclosure, just saying that up front. So the main group of patients that we see in the clinic are those with genetic mitochondrial disease. But of course, there's a variety of disorders where there's secondary mitochondrial dysfunction. And some of the main things that I see in the clinic are facioscapulohumeral muscular dystrophy, sporadic inclusion body myopathy, myotonic dystrophy type 1, and human aging. So this is a secondary mitochondrial disease that we all have. And it's pretty clear that we get mitochondrial dysfunction as we age, which is associated with many of the classic features of human aging. Essentially, disorder like SIBM really is an accelerated form of human aging, and people get dramatic muscle atrophy and weakness much earlier on in life with this disorder. And when you look at biopsies from these patients, they look like very aged individuals where we see mitochondrial dysfunction. So when we do a muscle biopsy on any of these disorders, we see the mitochondrial dysfunction reflected in an accumulation of abnormal mitochondria. So these essentially are called paracrystalline inclusions, which are an attempt for the cell, when it's exposed to poor energy output, to make more of the engines called mitochondria and try and extract more energy. Eventually, that becomes a sort of a failed process, and we accumulate these ragged red fibers, and eventually the cell can die. You can see here in the bottom panel, this is what's called a cytochrome C oxidase negative fiber. This is the main component of the mitochondria that extracts oxygen. And these do accumulate with aging, but more so in our patients with different muscle disorders. But it's a classic feature of many, but not all, mitochondrial disease. So failure to find this doesn't mean you don't have a mitochondrial disease, but when you see these, you're thinking it's either primary or secondary. So we've been very interested over the years in looking at how nutrition, nutraceutical compounds, what I call the pharma-nutraceutical approach, where we take a pharmacological approach to develop nutraceuticals. And of course, we're very interested in exercise, which I don't have time to talk about tonight. The reason why mitochondrial dysfunction is a targetable entity is that it leads to a variety of issues like oxidative stress, lower protein synthesis, inflammation, and we also get what's called stem cell exhaustion. In muscle, those stem cells are called satellite cells, and we see that we have fewer cells to regenerate our tissues as we get older. So one of the things that we wanted to see, first and foremost, very simple stuff. Do patients who have mobility impairments eat enough? And you can imagine if somebody has swallowing issues or they're weak, it's hard to shop, it's hard to cook, and sometimes hard to swallow. So we looked at 51 of our patients in this paper here with myotonic dystrophy, limb-girdle dystrophy, and FSH, and boys with Duchenne. And what we did was we analyzed their diet on 2 separate occasions for 3 days. So 2 weekdays and a weekend day, waited to 5 months later and did it again. We looked at the mean values and we compared it to what's called the Canadian Dietary Reference Intake. You might have heard of the RDA in the US, that's a recommended daily allowance, and they're essentially one and the same thing. So what we found, not unexpectedly, is that if people don't move very much, you don't have to eat very much, because if you keep eating as much as somebody who's walking around a lot, you're going to become obese. So we found that a variety of our patients just weren't getting enough calories. And if you don't take in enough food, it's no surprise that many of the vitamins that are important for human health are deficient. So what these numbers represent is the proportion of people not meeting even the basal requirements in the Canadian and US recommendation. And look at things here like vitamin E, which is an important antioxidant, very low. Vitamin D, these numbers are closer to 100% with the new guidelines, which are much higher, showing that for vitamin D, we actually need slightly higher levels. So we've actually looked at mitochondrial patients as well, and we've done analysis. Again, this is only 9 patients, and we've compared it to our publication in patients with muscular dystrophy. Suffice to say that whatever we're showing for muscular dystrophy, it's pretty much the same thing for patients with mitochondrial disease. Now, I'm going to also highlight a little later issues of obesity. Now, you know that the BMI, you've probably heard, is not the best marker of obesity. I'm going to show that in just a minute. And also a number of our patients seem to be lower in weight. Keep this in mind because I'm going to highlight this a little later in my talk. We've also gone on to measure deficiency states in our patients. So in the maroon here are 62 patients with mitochondrial disease. And these numbers are holding true today. We're now up to several hundred patients. And what we can see here is that we have about 16% of our mitochondrial patients when they first come to see us are deficient in vitamin B12. Now, that doesn't mean that you take super large amounts of B12. It means that if they're low, as is the case of 16% of our patients, it should be identified and supplemented. And why that's important is vitamin B12, if it's deficient, can cause neuropathy, it can cause dementia, it can cause a spinal cord issue called myelopathy. So missing the opportunity to treat something is like pouring gasoline on the fire. Folic acid functions very similar to vitamin B12. And look here, we have almost 9% of our patients are deficient in folate. In some of our children, we also measure the folate in the spinal fluid and see that up to 20% of kids have low folate in the CSF. Now, other things like vitamin D here, you can see it's only around 10 to 15%. But with the current guidelines, it's over 95% of our patients are not meeting current guidelines. What this number reflects is the amount of vitamin D in your blood to prevent rickets. So these patients are in the rickets range, which is a bone disease, which most people thought didn't exist anymore because that was back in sort of Victorian England when people with dark skin would come over and not have any sunlight. But we're seeing that up to 12% of our patients actually have rickets level vitamin D deficiency. Now, another thing with respect to diet is some of our patients have swallowing issues. And if you have swallowing issues, you have decreased energy intake, or at least it takes you twice as long to eat or 3 times as long. And one of the issues from a swallowing perspective is that if you do have difficulty swallowing, so for example, when you're eating, you're coughing afterwards or choking, and you're finding it difficult to swallow, especially dry foods, which reflects weakness at the back of your throat, you should consider getting a swallowing study. So this is a picture here of someone chewing on some food that has a dye in it so that we can see it, and they're trying to swallow. What you can see here is a pooling of the food in what's called the vallecula. This is very common in our CPEO patients, and we were one of the first to really describe this. This affects almost 80% of our patients with chronic progressive external ophthalmoplegia. So what can happen is when the food is pooling here, after you're done eating, it'll stay there, and eventually it can fall into your trachea and cause a pneumonia. So it's important to identify this, and there's a whole host of strategies that a speech-language pathologist can do to help you to improve your swallowing. So if you are choking after meals, or you find you're coughing after you're eating solid foods, even sometimes a half an hour later, it's because of this pooling, and you really should get one of these swallowing studies. We generally recommend taking a balanced multivitamin because, as you saw in our previous slide, many patients are insufficient. Now, there's no harm whatsoever, and you're not going to get toxic by taking a balanced multivitamin. These can be purchased, for example, from Costco. There's a multivitamin for men, one for women, one for seniors, and there's chewable vitamins for children. So generally, we would recommend for most people who are not getting adequate calories to take a multivitamin. We do recommend to check for deficiencies, the most common of which are folate, vitamin B12, vitamin D, and also to some extent vitamin E. And if they're deficient, it is low-hanging fruit to treat these things. And keep in mind that it's someone with a mitochondrial disease, or indeed any neurologic disorder, who shows some signs of deterioration. It's not always the disease. And too many doctors think anything that happens is the disease, and they forget about common things like becoming hypothyroid, becoming diabetic, getting a vitamin deficiency. So make sure that these things are checked, and don't just throw every decline down to just the underlying disease. Just a little aside is children who are falling off the growth curve with mitochondrial disease or muscular dystrophy, who can't swallow or maybe aren't taking enough calories. We often resort to a G-tube quite early because we can ensure adequate calories, we can ensure the mitochondrial cocktail, and ensure proper protein and calorie to feed them. For mitochondrial patients, generally we would recommend avoid fasting for prolonged periods, and that sort of made its way into the literature. There's a little bit of a caveat to that because sometimes when you fast for 10 to 12 hours, you activate something called autophagy, which may be of benefit. But I do think for especially our more sensitive children in particular who don't have the same reserves as adults, we would like to try and avoid fasting for long periods of time. So smaller meals are generally easier to digest, give you less GI upset, and it's usually easier for people to get adequate calories if you're having more frequent, smaller meals. Specific to complex 1 deficiency or people with PDH deficiency, we recommend consider trying a high-fat diet. Now, that doesn't mean a ketogenic diet for everyone, but certainly there was a study several years ago showing patients with isolated complex 1 deficiency had better exercise capacity with a high-fat diet because it can partially bypass the defect. We've mentioned treating the deficiencies, and I'll just highlight a couple of other ones that I think should be checked. One is copper. So copper deficiency can actually cause a problem with the spinal cord called myelopathy. And the other one is ferritin. Ferritin reflects your iron stores. Now, in general, most doctors won't replace iron stores unless you become anemic. Once you're anemic, you've kind of missed the bag, and that means that your hemoglobin stores are down. However, ferritin reflects the total body iron stores. And the mitochondria have what are called iron sulfur clusters. And studies have shown that if you are iron deficient, meaning a ferritin less than 50, your mitochondria are not functioning optimally. So generally, we like to keep the ferritin levels over 50 for optimal mitochondrial health. We also would suggest avoiding excessive alcohol consumption. We've seen in some of our patients with optic atrophy. Now, keep in mind, it's quite extreme. We've had people drinking 18 to 20 drinks a day, which can be toxic to the eye nerve. But in general, probably reasonable to keep it under 2 drinks a day. And also those with MELAS syndrome, we suggest avoiding monosodium glutamate, which sometimes when you go out to certain foods, especially Chinese fast food outlets, sometimes they use MSG, but it's used also in other ethnicities' cooking to enhance flavor, but that can trigger migraines. And keep in mind, too, what your triggers might be if you have migraines. Sometimes red wine, older cheeses can cause migraine headaches. So be particularly careful of that in MELAS patients, because a migraine in a MELAS patient can sometimes lead to strokes and seizures. So what happens when the mitochondria don't work well? And what are some of the cellular consequences and targetable areas that we can look at to try and provide nutraceutical support? So if the mitochondria doesn't work, so for example, if you had a cytochrome B mutation, which affects complex 3 here, normally the mitochondria take the food that we eat, we break it down to what are called reducing equivalents, which are little chunks of potential energy, and these are fed into the mitochondria. When oxygen, is present, then these food particles can eventually be taken apart, we call decarboxylated, and the potential energy can be used to pump these protons into what's called the intermembrane space. In the presence of oxygen, these free radicals, these electrons will flow, and if there's an impairment, it'll form what are called free radicals, which make these reactive oxygen species. Oxidative stress, you might have heard of that term, but these little free radicals are a problem if there's too many of them because they can damage DNA, protein, and lipids. And so we do know that many patients with mitochondrial disease will get a backflow of these electrons, which ultimately come from food and are needed to generate essentially ATP when oxygen is present. If they backflow, they can make these reactive oxygen species. And that's why most of the mitochondrial cocktails do contain some antioxidants to mop up these free radicals so they don't do their damage. There's a decrease in ATP generation, given that if you can't use the mitochondria, all you have left are very inefficient energy systems, which don't provide the same level of energy. One of them is creatine. So phosphocreatine is one of the energy stores in our brain, muscle, heart, and that provides energy, but it is limited. The only good thing is that we can supplement with creatine and increase that energy store. We also see that the cell tries to compensate by increasing mitochondria. There's a process called apoptosis, which eventually kills the cells, and the cell tries to increase antioxidant enzymes, but eventually they become overwhelmed, and we have to provide exogenous antioxidants in the presence of diet and or nutraceuticals to try and compensate for these increased free radicals. So these are some of the substrates that have been used to target some of the final common pathways. So if, for example, you have a defect at complex 1, people try to bypass the defect. Things like CoQ10, succinate, and riboflavin can partially do this. People have tried to lower lactate. So if you can't use mitochondria, you flux through what's called glycolysis, you make more lactic acid, and people have tried to lower that by putting more of the lactic acid into the mitochondria with a drug called dichloroacetate and thiamine. This failed in clinical trials because it caused damage to the nerves. Thiamine, I think, is a very appropriate and safe therapy. It's a water-soluble vitamin, and certainly anyone with PDH deficiency should be on thiamine. Antioxidants, we've talked before about mopping up the free radicals. Vitamin E, lipoic acid, vitamin C, coenzyme Q10 are all antioxidants. We are the ones who first suggested giving an alternative energy source with creatine, and I'll talk about that. And I don't have time to talk about these other strategies here, but I'm sure Tanya Tavasalo will talk at some point about exercise training. So the first thing that we did back in 1999 was look for mitochondrial and muscle disorders where creatine levels were very low. And if they're low, it makes sense to replace them. So we did find that mitochondrial DNA disorders had very low levels of total and phosphocreatine, muscular dystrophy, and inflammatory muscle disease. So we and others have gone on to see whether supplementing with creatine helps these people who are deficient. So what is creatine? Creatine is made by all of us every single day of our lives from kidney and pancreas to make what's called guanidino acetate, which is taken up from the liver and makes about 1 to 2 grams of creatine per day. We also get creatine from exogenous consumption. So fish is extremely high, and it's estimated that 10% of the Danish and Norwegian population are chronically creatine loaded because they eat so much herring, which has an extremely high concentration of creatine. If you are a vegan vegetarian, you get no creatine whatsoever in your diet, and your endogenous synthesis can't keep up. And they've shown that muscle and brain creatine levels are low. And in those vegan vegetarians, when you give them creatine, it actually improves their mental capacity, cognitive functioning, and problem-solving ability. So what happens with creatine is most of it ends up in muscle to be used to provide energy, but it also decreases muscle protein breakdown. And creatine is eventually broken down in muscle to creatinine and excreted through the kidneys. So the top here is a muscle contracting. When muscles contract, we need energy. So the first buffer for energy is ATP, which we have in very limited reserves in our muscle. Within a fraction of a second, our ATP levels drop and we have to resynthesize them. So what happens is phosphocreatine exists in the muscle in very large quantities to buffer this. So when ATP is broken down to contract muscle, it is rephosphorylated back to ATP by phosphocreatine. Now, although the concentration is very high in muscle, it still only provides for 8 to 10 seconds of maximal muscle contraction. But what it does is it provides an energy shuttle. So when we start contracting muscle, we get an increase in creatine, which crosses into the mitochondria to actually activate the mitochondria. So there's a very elaborate creatine phosphocreatine shuttle whereby energy stress in the cytosol, or the sort of outer part of the cells, triggers the mitochondria to start respiring. And studies have shown that adding creatine to a cell system turns on mitochondria and gets them respiring. So for this reason, we suggested it would be reasonable to try this in mitochondrial patients based on a whole bunch of observations. People have shown, we and others, that older adults increase their muscle, increase strength and power. Innumerable animal studies have shown in mouse models, including our studies of Lou Gehrig's disease, Huntington's, and Parkinson's. There's a decrease in what's called neurotoxicity, or damage to the neurons. There's a direct and indirect antioxidant effect. And in studies where they make a womb have low oxygen to simulate what happens to poor children who get cerebral palsy, there's much less damage to the brain of animals if you have anoxia in the womb. And people are now talking about supplementing pregnant women with creatine to prevent children from birth trauma. The other thing that's been shown is with stroke. In animal models of stroke, if the animals are given creatine before a stroke, there's much less damage. That's also been shown in head injury as well. So for patients with MELAS, you don't know when you're going to get the stroke, so loading with creatine would seem to make some sense. And studies in the muscular dystrophy mouse showed increases in mitochondrial function. So we've done studies. This is a study of exercise and creatine in older adults. These are men and women over the age of 65 who did an exercise program 3 times per week. And in those supplemented with creatine, you can see that we could increase the muscle creatine levels dramatically, and that was statistically significant. No increase just with training, as if you don't take any creatine. And what that meant is they got more muscle mass and they got more strength gains when they were lifting weights. So clearly, anyone who's doing weight training, creatine is just low-hanging fruit. Probably 200 studies have shown similar results, that we can better increase muscle mass and strength if we're exercise training. Now, what if you're not exercise training? This was our first study in patients with mitochondrial disease with just creatine, nothing else in the supplement. And we had 7 patients with MELAS syndrome, randomized crossover. What that means is neither us nor the patients knew what they were on. They took a placebo, they took the drug, or they took drug and placebo. And only after the study was over did we know what they took, and we could do the analysis. So they took 10 grams a day, which is essentially 2 heaping teaspoons. And then we put them down to essentially 1 level teaspoon for a week. And what we found was strength went up in both the hand and the foot by about 11%. And this is a fatiguing trial. So we did this on and off for a minute. And what we found is that strength was better maintained. Now, you might say, well, who cares about 11%? That means nothing. But if you're doing repetitive activity, like let's say you were vacuuming for a minute, or any type of repetitive activity, if you can get 11% extra bang for your buck, that does have some consequences of benefit. The other way to think about it is in our boys with Duchenne dystrophy, which is a horrible degenerative disease where boys die, we poison them with prednisone. We give them one of the most toxic drugs known to mankind with tons of side effects. Every one of them becomes osteoporotic. They all get cataracts. They all become diabetic and obese later on, and they get a 6% increase in strength. And yet that was deemed to be beneficial enough that we keep giving them this medication. Whereas with creatine, essentially no side effects. Now, it was a short-term study, so we didn't see that their maximal aerobic capacity, which is a reflection of mitochondrial disease, got better. So we and others have used creatine in patients with Duchenne muscular dystrophy. There have been at least 10 studies now throughout the world with over 200 patients now enrolled. At the time when I wrote this, there was only 192. But what we found was on average an 8.5% increase in strength and about 1.5 pounds increase in muscle mass. So just taking one supplement is probably not beneficial when there's multiple final common pathways. As I pointed out, when a mitochondria doesn't work, we have oxidative stress, we damage telomeres, we deplete stem cells, we cause inflammation, and there's a variety of ways we can use multiple ingredients to target several of these pathways to try and get more bang for your buck. Now, we have published a paper in the muscular dystrophy mouse where we used 4 different compounds versus creatine alone, showing that the 4 compounds together, which included creatine, was much superior, and also much superior to the drug of choice, which is FDA approved, which is prednisone. Prednisone, I hasten to add, however, plus our multi-ingredient supplement in that study was shown to be better. So any drug that's being developed that's out there, in general, the mitochondrial cocktail does not negate the benefits. It is likely additive to the benefits. And that was very sharp focus when we did our muscular dystrophy study, that we added to the standard of care, and there was a dramatic improvement. Now, what about mitochondrial disease? What are the optimal mitochondrial cocktails? Well, first, I'll just show you this study here. This is the muscular dystrophy mouse. And what I have on the top here are measures of improvement like strength, fatigue. This is a balance and fatigue test. This is a reflection of damage. This is how fat they get. And I'll just show you a couple of things. So number 1, prednisone is the standard of care. So this is the only FDA approved drug for Duchenne muscular dystrophy. And what we have here, these numbers are the rank. Number 1 is the best performing. Number 7 is the worst performing. So you can see here that prednisone, accepted FDA drug, really didn't perform that well. It was never number 1, and here, damage to the muscle, it was rated number 2. Now let's look at other ones here. We've mentioned creatine monohydrate, and again, we've shown in clinical trials it was beneficial. Seems to score about the same, if not maybe, a bit better than prednisone, but really not great. But if we combine, this is an amino acid, this is creatine, this is an antioxidant, and this is a medication to lower body fat, which is found in milk. And what you see is if you give the combination of all of these without prednisone, it's actually superior to prednisone. Many more of these are higher numbers, lower numbers, meaning they're better. So number 1 is the best, number 2 is second best. But look here, this is our combination plus prednisone. Almost across the board, it's consistently the best supplement. So again, pointing out that multi-ingredient supplements work better than individual supplements if you're targeting multiple final common pathways of the disease in question. So we tried this strategy to target multiple final common pathways, and this was the study that I paid for out of my own clinical overage, which I could take home to pay my mortgage, but instead I chose to put it into a clinical study because I was firmly of the belief that this would work. So we used CoQ10, vitamin E, lipoic acid, and creatine to provide for mitochondrial antioxidants, also a membrane antioxidant, and also antioxidants that provide what's called a redox couple, so they recharge each other, and you know the reasons for the creatine. So we base this upon the fact that Barbara Marriage had published a few years ago using a multi-ingredient supplement with CoQ10, carnitine, B complex, vitamin K, and C, showing in patients with Leber's and CPO and 3 other miscellaneous disorders that they could increase the CoQ10 concentration and ATP production in the white blood cells. Now, they didn't see any benefit to lactate, so it didn't seem to increase whole body mitochondrial function, but at least it was the first step to try and look at a combination mitochondrial cocktail in a scientific manner. So we followed up on that with the combination that I mentioned. So this was published in Muscle and Nerve in 2007. So we had patients 2 months on supplement or placebo, washout for 2 months, and they crossed over. So everyone got the drug or placebo, and we compared the results on the drug to those on placebo. So we had pretty low dose CoQ10. We now use 200 milligrams twice a day. Pretty low dose vitamin E, creatine, and alpha lipoic acid. We had 16 patients with MELAS, MERF, Kern-Sayer, CPO, all the classic things, all genetically confirmed. And we showed that the CoQ10, and again, everyone talks about idebenone, they talk about ubiquinol versus ubiquinone. Ubiquinone is the main CoQ10. All of that really stemmed from the fact that a lot of the early forms, like 15, 20, 30 years ago, of CoQ10 weren't well absorbed. This is one of the newer forms of CoQ10 called Qsorb, and you can see that it definitely gets well absorbed. So really, idebenone and all these other things came out because the original forms were not well absorbed. But really, the newer forms of CoQ10 perform very similar across the board. Keep in mind, this is not ubiquinol, this is ubiquinone, regular CoQ10 that you can get from Costco. This is a marker of oxidative damage, which is what I mentioned before. If you get these free radicals, they damage. This is DNA. So this is DNA damage was better on the supplement. And we showed that lactate was lower. So lactate, if it goes down, means the mitochondrial function goes up. And then we also looked at a measure of damage to the lipid in the cell, and that was lower as well. So again, self-funded, so we didn't have long-term clinical outcomes, but it shows that all of the biomarkers of mitochondrial disease were favorably enhanced on this cocktail. It was a randomized double-blind, external party held the code, so we had no way of influencing the results. And the publication was the first really to show these benefits. So our government in Ontario now funds this cocktail. Actually, here's a picture. I'll hide the patient's name of what we get in Ontario. So this is the actual cocktail, and it's funded through a program here in Ontario based on the fact that we actually had the first randomized clinical trial in mitochondrial patients. Now, I was criticized. People said, well, Mark, you're full of crap. The only thing that works, of course, is coenzyme Q10. So I said, well, duh, did you not read my paper in 2001 where we said that multiple final common pathways work? It's been shown in cancer therapy. It's been shown in muscular dystrophy. But the naysayers said it's all CoQ10. So I said, okay, fine. I'm going to use my extra clinical overage, not take it home to pay the mortgage, and do another study. So I'm not very happy that I had to do this study for nothing. So we did the same sort of a study, 2 months on CoQ10, 2 months on placebo, or vice versa. We gave them very high doses of CoQ10, 600 milligrams twice a day, 30 patients this time with all the classics. And we did MR spectroscopy, which cost a fortune in the brain, lactate, oxidative stress, the whole 9 yards. And what did we show? Nothing. So unlike our first paper where we showed that the markers of mitochondrial disease were better, we didn't see any improvement whatsoever, even with very high doses of CoQ10. The cycloergometry improved a tiny bit, which isn't that surprising, but the markers reflective of mitochondrial disease were not enhanced. So one of the things that I mentioned earlier when I was talking about our diet studies, we always look at body composition, because energy in, energy out, you get changes in your body composition. Obviously, we want to promote more muscle for most patients, and we want to decrease the amount of body fat, because if you've got weakness or fatigue and you have extra body fat and you have to pick it up and move, that's just extra weight that you have to carry around. Also, we know that excessive body fat leading to overweight and obesity can further compromise mitochondrial function. So I wanted to highlight an important problem that we see, and this is in mitochondrial patients and all of our muscle patients. And what it is that the BMI does not reflect your body composition very well. So when you go to your doctor, you get a BMI done, which is your height and your weight go into an equation. They give you this BMI. If it's over 30, you're obese. If it's under 18.5, you're too thin. So the problem that we have, you can see here that if we do 18.5, you can see that there's a lot of patients, especially our Duchenne boys, but also Becker muscular dystrophy. And a young lady I saw today who has CPEO, her body mass index was 16.5, which is profoundly underweight. So if you look at her and you look at all of these patients, they would be considered underweight. And people would say, feed them more, fatten them up, give them more, they're too skinny. However, all of these patients here are actually obese. So everyone past this line here is in the obese range. So how we know that is BMI is just a rough, crude reflection of body fat, but we have a $200,000 machine called a DEXA scanner, which tells us exactly how much body fat you have. And what this is reflecting is that when we actually measure the body fat, many patients who appear to be normal weight or underweight are actually obese when we measure it. And that's not that surprising, because if you shrink your muscle a lot, and the person can look skinny, but much of that still remains fat. In fact, today, that lady I was telling you about, who was grossly underweight by BMI, had 47% of her entire body was fat. So she was massively obese, by proper measurements, but being reported to her doctor when you just measure BMI as being underweight. So overweightness and obesity is not just a problem for the general population. In fact, in the US, depending on the state, anywhere from 50 to 70% of patients are overweight or obese. It's even more of a problem in many of our patients because of the decreased activity that they're doing. So we know here, as I mentioned, that about on average, 66% of people in the US are overweight and obese. And you can see from 1985 to 2014, and it's even worse now, there's a greater proportion of the population that's obese. And what you can see is obviously everyone here, you'd have to be living under a rock not to see all the ads about Ozempic and all this stuff. Do you take Ozempic? Ask your doctor about Ozempic, which is a drug that tells your brain to stop eating. The challenge I have with patients with mitochondrial disease and muscular dystrophy is we already saw from my research, many people aren't eating enough. Then you tell them to eat even less. People are going to be going for very calorically dense foods, which are, not very nutrient dense, and running into even more nutrient deficiencies if you tell them to stop eating. And in fact, even in able-bodied individuals, when they take drugs like Ozempic or they get bariatric surgery, a substantial amount of the weight loss is muscle loss. Because when you lose that much weight, you tend to lose muscle. So one of the themes just to keep in the back of your mind is, can we lose weight and still hold on to muscle? So this is a major issue and much more of an issue in muscular dystrophy and mitochondrial patients. Now, one disorder we know about: cardiovascular disease, type 2 diabetes, arthritis, and even some cancers are at higher risk with obesity. But fatty liver disease is thought to be the new hepatitis C. So hep C was a viral infection which is leading to cirrhosis and causing liver damage. But now what we're seeing is, with this rise of obesity, more people are damaging their liver and going on to fibrosis because of the fat being deposited in their livers. We know as well that obesity itself, type 2 diabetes, fatty liver disease, all of these issues that we see related to obesity are also associated with impaired mitochondrial function. So a classic example of secondary mitochondrial dysfunction. So think about it. If you've got a genetic mitochondrial disease, then you've got a metabolic disorder like type 2 diabetes or obesity, you're just pouring gasoline on the fire. And that can become a real issue because in aging, we call it obesity with low muscle mass. But essentially, every one of our patients with muscle disease and mitochondrial disease more or less has the same scenario. Decreased muscle, sometimes called sarcopenia, increase in body fat. Not a good combination to have. So again, we've been thinking, can we use multiple ingredient supplement strategies to try and target these final common pathways? And will it have a beneficial effect on some of these more common disorders? So as I mentioned, the goal for most patients who are getting old, athletes, patients with muscular dystrophy, and in fact, most people want to increase muscle and decrease body fat. The challenge, again, for a lot of people as they get older, or if you have muscle disease, which we saw in one of our patients with SMA, who had bariatric surgery because he was quite obese. When we put him on our strength device, he lost 45% of his strength because he lost so much muscle mass. And that's a real problem with Ozempic and other GLP-1 receptor agonists and bariatric surgery. So we've tried to see, can we improve muscle mass and also get fat loss? So probably the best way to do that, of course, is exercise. Now, if you just exercise, this is a study in older people, 20 men and 20 women, where we did 6 months of exercise, coming into the gym, lifting weights, and you can see that you can gain muscle while you lose a little bit of fat. However, can that be enhanced? So we know creatine is beneficial, so we decided to put creatine in there. And one of the most popular weight loss supplements in the US and North America is called conjugated linoleic acid, which comes from milk. And what you can see is taking both of them, and it's likely that creatine drove a greater increase in muscle mass, and the CLA drove a greater reduction in fat. So while you exercise, you can both gain muscle and lose fat. It is possible. And it is definitely accentuated with certain supplements. However, we wanted to take this one step further and really take a look at this whole mitochondrial enhancement thing. So we did some studies in obesity, and the mouse model here, we give them extremely high fat diet and they get very obese and they get fatty liver disease. However, when we wanted to look for supplements, we want supplements that work with exercise, because we know that exercise is the most effective weight loss strategy. It's the most effective thing to improve your mitochondria, the most effective way to improve your health span. Can we still work in the face of exercise. And some of you might say, well, why do you even think about that? The reason we did is that certain antioxidants can blunt the benefits of exercise. So a very good study came out a few years ago showing that vitamin E and vitamin C together blunted and completely prevented all the benefits of exercise. So I was a little worried, given that what I'm going to show you has a bunch of antioxidants in it, that maybe we would blunt the benefits of exercise, and ethically I could not promote a product that did such. So what we did is we scoured the world literature for the weight loss components, and we looked for 5: green tea, green coffee, forskolin, which is a mint extract, CLA, the thing that we just talked about, and black tea extract. We then looked at our Mito core, the ALA, the CoQ10, vitamin E, creatine as well, and beetroot. And what we did is we did all sorts of combinations in our mice, and we came down to these essential 7 ingredients, which is why we eventually called this Trim 7, which was Health Canada approved with that name because of the 7 ingredients. So what we did is you make the mice fat by giving them a high-fat diet, keep giving them high-fat diet, they get fatter and fatter. Exercise mice, that's the purple line here, they get skinnier. Not right back to normal, but they get skinnier. What I was worried about is this combination here. This is the eventual combination called Trim 7, was almost as good as exercise, but when we exercised, it doubled the benefits. So my worry was it was going to blunt the benefits, but in the presence of exercise and the supplement, you get even more. So anything that you try, remember that exercise is the most consistently proven to be effective therapy for mitochondrial disease and muscular dystrophy and human aging. So what we found is that essentially your white adipose tissue, which is the fat, if you pinch an inch under your belly, that turns into a furnace. So we increase mitochondria. So this is essentially with a high-fat diet compared to control here. You can see how much you knock down the master regulator of making new mitochondria called PGC1 alpha. And this is a component of the 4th enzyme in the mitochondria, down by about 60%. Now, with these supplements, we tried a whole bunch of them. This is only 2 of them. This ended up being called Trim 7. So you can see that it's definitely much better than the high-fat diet. This is high-fat diet plus this enhancer. But again, the consistent theme is exercise further potentiates anything that you're taking. We turned on lipid oxidation, so we burn more fat. And we proved that also by putting them in special cages where we could measure how much fat they burn. And this is why we chose ultimately Trim 7. So this is the jewel in the crown. This is called UCP1, which essentially uncouples the mitochondria in the brown adipose tissue, so they burn a bit more energy. And this went up mostly in the Trim 7. And then we went on, also lowered inflammation. So this is a reduction in inflammation, so huge increase in inflammation. And that was lowered with the supplements and exercise. Now, one of my buddies didn't believe me. He's a fatty liver expert. So we gave him the Trim 7 diet and what's called a chow diet. And what he found, and he's not part of our company, and we didn't pay him anything. He did this out of the goodness of his heart because he didn't believe me. He completely reversed fatty liver disease, lowered body fat, lowered something called PCSK9, which is a target for a new drug that people may be on for lowering cholesterol. And we lowered cholesterol. So this is the fat on the high fat, and that's with the Trim 7. And again, once they switched to the Trim 7, they went back to controlled diet weight. This is what it looks like. So this is a liver full of fat. And then with the Trim 7, it goes pretty much back to normal and pretty similar to exercise. I won't get into that. So what we did is we went on to do a clinical study to see, does this work in the real world in humans? So what we did is we had 60 overweight men and women, young and middle-aged. They were on this supplement for 3 months or a placebo. And the primary end point, which FDA and Health Canada want, is weight. However, more and more people are so aware now of the fact that you lose muscle mass with some of these other strategies. We did a DEXA scan to look at muscle mass. And what we found here is that when people were on the Trim 7, more people lost weight here in green versus the placebo. Everyone was just given diet advice, exercise advice, just like you are from your family doctor. Bye-bye, we'll see you in 3 months. And unfortunately, COVID hit. So you can see some people who already started off overweight and obese became even less active and ate more. But all of these people were treated the same. And the only difference is they took Trim 7. This was completely independently blinded. Third party held the code, and our research group holds the code independently if anyone doesn't believe the data. we showed about a 26 to 28% drop in fatty liver markers, but no loss of muscle mass. So it's really the first strategy where people have lost body fat without losing muscle mass without exercise. Of course, I've already shown you, you throw exercise into the mix, everything's better. And we're now doing a study with the University of Waterloo. Independently, they're looking at TRiM7 and a muscle enhancer called Muscle 5 to see if it works in younger people who are doing exercise. So in general, just to summarize everything I've talked about, we really firmly believe, based on our clinical research study, which had no involvement whatsoever from pharma, of self-funded, that CoQ10, lipoic acid, vitamin E, and creatine really are the core, I think, of the mitochondrial cocktail. We've been giving this to patients now for over 20 years. If you have complex 1 deficiency, I'd suggest adding riboflavin. If you have PDH deficiency, I'd add thiamine. For MELAS syndrome in particular, if you should get your blood amino acids measured, and nice work by Fernando Scagli has clearly shown that a number of patients have low arginine, and he was one of the first who was smart enough to say we should replace this because arginine and citrulline, which are very similar, can release these things called nitric oxide, which can vasodilate. So you get rid of the vasospasm during an acute stroke in MELAS syndrome. So we give intravenous arginine during a stroke, but we usually replace the citrulline or arginine. You can do either one. They do about the same. Now, there's some novel therapies out there. Marnie Falk, a wonderful friend, colleague, and clinical scientist, has done some stuff with niacin, and there's a whole bunch of new niacin derivatives which people have worked on. A big one called NAR was studied in huge doses, which failed in a phase 3 clinical trial, but people are still touting it as being helpful. Beetroot on its own has been shown to improve mitochondrial efficiency, which is why we put it into TRiM7. TRiM7, again, has a combination of all of these things. And there is some interesting data coming out with a compound from pomegranates called urolithin A. One of my colleagues, Stu Phillips, is doing a study, and we'll see what that shows, but that holds some promise for sure. We also strongly suggest to measure and replace any deficiencies. Now, practically, if you're trying any mitochondrial supplement or any cocktail combination, start with one every few days, add the other one, and listen to what Mother Nature did. All vitamins and minerals came in with food, so never take it on an empty stomach, or you're going to get an upset stomach. Take it right in the middle of your food, and that's much better absorbed, and you won't have as much intolerance. Other thing I would suggest is if you're going to try certain things, measure some outcomes. Measure your heart rate, for example, going up a flight of stairs. Measure some biochemistry, lactate, things like plasma amino acids, GDF-15. And many of these your doctors can do, but even simply at home, if you want to follow your body composition, there's little scales that have those silver pads. That's called bioelectric impedance, to tell you not just your weight, but your composition. Are you losing fat? And that's an important thing. And some of these newer scales, even only $130 scales, are quite accurate at telling you how much body fat and muscle you have. So consider one of those if you're going to try something. So again, these are some of the doses. I can leave these for folks. I think, UMDF has many of these on its website. This is pretty standard stuff. But again, if anyone needs it, I can leave my slides. People can take a look. If people are obese and overweight, again, TRiM7 is one thing to consider, but you can create your own with the mitochondrial cocktail. And we've got also this thing called forskolin, beetroot extract, green tea and green coffee bean extract contained within that. So I just wanted to thank all the folks in the lab, the clinic, our national and international collaborators. I'm sure you all know Bob Navio, who won the UMDF Clinician Scientist Award last year. An incredible scientist, friend, and colleague, and a host of others. And then some of our research has been supported by UMDF, Mito Canada, McMaster, CIHR, and Exerkine, and a host of other supporters to our clinic. Dan Wright and family. Dan was the chair of the UMDF Scientific Committee, Board of Directors, I should say. And Warren Lammert has been a donor to UMDF and to our clinic. Thanks very much.
Oh, are you still there, Dr. Tarnopolsky?
Yeah, can you hear me?
Yeah, yes, I can. I was having trouble getting myself out on camera. We have a few minutes left, and in this next few minutes, I'm going to go through a few questions. I just want to let our audience know that if you did submit a question into the Q&A and we do not get to it tonight, we will do our best to get your question answered post-event. If you were an anonymous, if you submitted your question anonymously, you may see the answers to your question in a transcript following this webcast. So the transcript is probably going to take a few weeks, but just know that we're going to do our best to get things answered. So I've pulled together a little bit of a summary of some of the questions that we had. And I would say of all of the questions, we had several surrounding creatine.
Yeah.
Can you tell us a little bit about it? Are there different types? What kind should people buy? If a person's a vegan, should they take more? Just give us a little rundown on creatine and what we need to know about that particular.
Yeah, so there's many myths about creatine, and what I can do if maybe I could just give it to you to share with everyone. We have a common myths and how to take creatine appropriately, white paper that we've written, and that can go through things. First and foremost, creatine monohydrate. Do not buy any other type other than creatine monohydrate. All of the preclinical work was done with creatine monohydrate. All of the clinical trials, like 99% of them, are all done with creatine monohydrate. What that means is creatine is the molecule we care about. If it's creatine succinate, creatine monohydrate, monohydrate just means there's a water molecule stuck to it. But at the end of the day, when it comes into your body, it's just creatine. So all the other hand-waving garbage about other ones being better absorbed, it is complete fabrication. So creatine monohydrate is what you want. Number two, never, ever, I'll just show you something here. Never buy liquid, ever. And I'll show you why. So I'm not going to show where this came from, but this is a liquid that is sold. This has been sitting in my cupboard for 10 years. So what you have is liquid on top, and you've got creatine sitting on the bottom as this white powder. See, it's orange and it's white powder. So anytime, and this has been known for 25 years, you put creatine into a liquid and let it sit, it converts to creatinine. So anyone who tries to sell you creatine liquid, garbage, garbage, garbage. It does not work. It gets converted to creatinine. So, then there was a company that was actually sued because they were selling these little droppers of creatine for, well, it wasn't creatine, it was garbage. It was just creatinine with a few drops, saying that that's the same as 5 grams of creatine. So no liquid. Next, with creatine, it's 100 milligrams per kilogram is the dose. Now, best way of thinking about it, if you're an adult, 1 heaping teaspoon should be sufficient for most adults. Start low, just like everything. Start with half a dose, get used to it. And generally with creatine, what we do is mix it into applesauce or yogurt or whatever. I don't have any here. I've got some in my clinic, but essentially it's just a white powder. It does not dissolve. So it will sink to the bottom. So you have to shake it up or put it into something that's semi-viscous, like, applesauce, and don't heat it. So heating it for 10 or 15 minutes will convert it to creatinine. So you can put it in your coffee, but not when it's piping hot. Let it go down to about 75 degrees Celsius, and then you can mix it in when it's a little bit lukewarm. Or mix it in milk and then put it in your coffee if you want to try it that way. But you have to keep stirring it because it'll settle to the bottom. So with creatine, don't load. In the old days, the athletes used to take 20 grams, which is, like 3 tablespoons a day. You do not need that. Studies have shown clearly that you can load the brain and you can load muscle with a lower constant dose. So again, that heaping teaspoon a day is sufficient for most adults. And for children, just remember it's 100 milligrams per kilogram per day. And you can divide it in doses. So if it's hard to get, let's say you've got a kid with a feeding tube, what we do is we divide it into 4 tiny little doses throughout the day. And at the end of, a couple of weeks, your brain is loaded the same way. And you can give it once a day too, because it's got a very long half-life. So there's, I've got a million things I could talk about with the creatine. But if there's any other creatine specific questions, I can get into it. But it's all in our creatine information sheet that I can leave for everyone to enjoy.
There was one very specific thing about creatine, and it was for vegans. Is there a reason that they need a higher dose?
Yeah. So vegans get zero from their diet. And we know when you do muscle biopsies, their muscles are about 30% lower in concentration. And so for a vegan, you don't need any more than what I've suggested. You're going to essentially, this is a little more the average person needs, but a vegan is still going to get up to like 150 millimoles per kilogram dry muscle mass and load the brain as well. So I just stick to the same doses. All I would say is that if you're a vegan, you will get much more bang from your buck, because the most important thing is replacing a deficiency is usually much more impactful than trying to supercompensate a sufficient state.
And this is a general question about supplements, but I think we could be more specific and talk about CoQ10, because I think that's one that many of our patients take. How do they select the right one? What would you do? How would you approach finding the right supplement? Where do you buy it? What kinds are more bioavailable? What kinds are to be avoided? How
Yeah,
does a patient address that?
I would say the first thing is, if it's too good to be true, it probably is. Make sure that supplements that you take were not from TikTok or anything. All of our research is published on what's called PubMed. So that's the first place I would look if you're thinking about supplement A, B, or C, or something that comes out. Check it out on PubMed, because PubMed is the National Sciences Library through the NIH. And these are peer-reviewed papers that go on PubMed. So that means it's undergone some scientific review, some credibility. Now, again, even there, some stuff can get on that's not the highest quality, but that's a minimum. Is it the supplement you're thinking of should be published on PubMed. So, of course, CoQ10, you'll get thousands of hits. But any new thing that comes out where someone says they put some insect wing into a supplement, check and see if there's a good publication to support it in PubMed, which is free and available to everyone. So the next thing you should think about, which is easier in Canada than it is in the US. In Canada, they've had concerns, which I've had for 20 years, about, we spend millions and millions of dollars creating our supplements, doing preclinical work, proving safety, doing it just the way a pharma company does. And some charlatan can finish grade 12 and just put something on a label and sell it. And until they get caught, they've made millions of dollars. So in Canada, they've come up with what's called the NPN number. So what you have to do is, if it has an NPN number on it, and I don't have any supplements here, unfortunately, that show it, but that means that it's gone through Health Canada's nutritional division, and we have to follow very, very rigid guidelines in terms of purity, where it comes from. We have to submit samples to ensure that our expiry date, we're still within 10% of label claim. Now, in the States, how can you protect yourself? Number one, go for the bigger reputable companies, I would suggest. Think about buying power. Costco can't afford to get sued and to buy crappy stuff. Costco has incredible buying power. So just as an example, my wife and I were buying our CoQ10 from Costco, because Costco's got incredible buying power, and they go to the highest sources, and they can only afford to go to contract manufacturing associations. They can't be cheap because they've got so much buying power, and they can't afford to have crappy stuff. So Costco is a reasonable place for your vitamin D or vitamin E, CoQ10. These are all reputable sources. So I would say that would be one thing to consider. Always start low, every few days, add the next one to get your body used to it. And what else can I say about that? Yeah, creatine, there is a company called Alzchem in Germany, and most of the most reputable companies that are making creatine, they'll say German creatine on it. If you see German creatine or Alzchem, which is, of course, where we buy ours from, that's the top contract manufacturing organization in the world for making creatine. So that would be a good reputable source for your creatine.
Well, thank you. Well, it is 8:01, and we're going to have to wrap things up. Again, I just want to remind our attendees that we will be trying to get answers to your questions post-event. I want to thank Dr. Tarnopolsky for so much information today. This valuable resource will appear on UMGF's YouTube channel and other places on our website, so look for that. We're really glad that you all were able to join us, and please mark your calendar for November 15th for our next Ask the Mito Doc webcast series. We're going to be doing something a little bit different this time. We're going to have, for those of you that have attended Symposium, you know about our Coffee and Conversation event, which is a a structured networking time where you're able to ask questions in a more casual environment. And we have a couple of topics we're going to be covering. One is Mito 101 for both adults and for pediatric patients. So what have you always wanted to know about Mito? And we'll have a physician in the room with you. And then we'll also be talking about patient rights and responsibilities so that people can kind of talk about the specific things that they might be encountering with insurance companies and with government programs, etc. So we hope you'll join us for November's Ask the Mito Doc. Again, you will be able to register on our website or through an e-blast that you receive. Again, thank you, Dr. Tarnopolsky, for all of this amazing information. And for all of our attendees, we'll see you next month.
Thank you.